Good evening, everyone. We, as a group for focused studies in breast cancer, we have been organizing multiple CMEs to better understand the biology of breast cancer. To start this, I would like to invite Dr. Arun Goyal, who is the backbone of Academy in Max Hospital and Senior Director at Surgical Oncology Department. Good evening, sir. Over to you, sir.
Thank you, Dr. Falta, and thanks for all the nice words. I don't deserve that much. Welcome to all my colleagues, all the faculty members, and all the audience who are there. We are sorry for being delayed by a few minutes because of some power issues. As Dr. Safalta mentioned that we have been organizing these events regularly. It is now nearly 2 years. And during these 2 years, we have had nearly 20 webinars and 2 conferences, all in the field of breast cancer. And overall, our approach has been to do somewhat focused events, taking one particular topic. While COVID has definitely significantly reduced and physical events have started, but I believe that the virtual format is here to stay, and it gives a lot of advantages like organizing faculty from multiple areas of the country and at times even international faculty also, and it is able to reach audiences in large parts of the country and outside the country also. So we hope to continue with this series of events as long as we get a good response, which has been continuing till now. So the topic today is triple negative breast cancer. So from the time that we started understanding breast cancer as a sort of group of different biological subtypes, so-called intrinsic subtypes, while triple negative not exactly similar to basal, but this is what we follow commonly because genomic profiling is not routinely available. The basic issue from the beginning has been that triple negative, we did not have any identifiable targets. So it was always considered as a problem area for management, but we have made significant progress, a much better understanding of biology. Now targeted therapies are being proven in randomized trials. So these are exciting times. And with that, I would like to hand over again for the show to go on. Thank you.
TNBCs, they lack the approved targets in breast cancer treatment. So considerable effort has been made to understand the biology of the driving force in TNBCs, which is heterogeneous in itself. For this, I would like to invite Dr. Sandeep Mathur, who is Professor, Department of Pathology at AIIMS, Delhi, and who is having special interest in TNBC. Over to you, sir. Welcome, sir.
Yeah, thank you, Dr. Goyal and Dr. Safalta. I hope I am audible to all of you.
Yes, sir.
Okay. I'll take a minute to share my screen. Is my screen visible?
Yes, sir, it's visible.
And I'm clearly audible. So
yes,
let me. So yeah, I have been assigned this task of giving some insight about the understanding of pathology of triple negative breast cancer. So I'll take this opportunity to talk a bit about triple negative breast cancer from the pathology perspective. And as already my clinical friends have told about the difficulties encountered in triple negative breast cancer are mainly there are no good therapeutic targets. So I'll be giving a little bit of sneak preview of the therapeutic targets as well, although I'm not the specialist in that and I don't have the time and the forum to go into the details of that. But I'll definitely all the same be talking a little bit about it. And I'm aware that subsequent speakers will be talking in more details on that. So just a brief introduction that, the parameters currently available, they are insufficient to reflect fully the biological heterogeneity of breast cancers as such. Because you may have breast cancers looking morphologically similar like for us pathologists, but they vary in their behavior and response to various therapies. So it's quite heterogeneous, and the optimal therapeutic approaches may not be different, may be different for different classes of breast cancer, which we now many times recognize them as molecular classes of these breast tumors. So this story began with the study by Peru et al. In which analyzed breast cancer gene expression patterns from cDNA microarrays and identified the intrinsic gene signatures of luminal A and B, basal-like, HER2 enriched, and normal breast-like cancer. So we all know about that story. So, but genomic analysis is really difficult in routine practice. So people have developed IHC surrogates for molecular classes of breast cancer, which all of us routinely deploy in clinical practice. As you know, the standard thing to do is do a ER, PR, HER2 and Ki67. You can have ER negative or ER positive tumors. Now, ER negative tumors, when they are also HER2 positive,
Sandeep sir, we are not able to hear you.
Hello, Dr. Sandeep, can you hear us?
or they may classify into normal basal breast-like tumor. Yeah.
Dr. Sandeep, we lost you for about last 30 seconds or so.
Oh, I'm so sorry. Yeah, I got just a flash saying the internet was unstable. So, did I convey this slide?
Yes,
Yeah.
yes.
Okay. So what I was talking was that because this genomic classification is difficult, we have developed IHC surrogates, which we all use in routine practice. So what I was saying was that I was going through this algorithm where you have ER negative, HER2 positive tumor, we classify this as HER2 enriched. If both are negative, we can go for these basal markers like CK5/6, EGFR, which are, if found to be positive, that classifies a tumor on the basis of IHC as a basal phenotype. And when they are negative, you call them non-basal or normal breast-like. While if you go to the ER positive arm of this algorithm, when you have ER positivity and HER2 positivity, you can have them as, call them as luminal but HER2, luminal HER2 types. And when you have both HER2 negativity and a Ki low, then it is a luminal A, and the high Ki usually considered more than 20%, then it is a luminal B kind of a tumor. So this is a depiction of what we routinely see as pathologists in our practice. This is a breast carcinoma, which is ER positive. Ki is very low, as you can see, only few cells, a typical luminal A, typical luminal B type of tumor with a high Ki67 and ER positivity, HER2 negativity. And you can also have HER2 positivity in a luminal tumor where you classify them as luminal HER2. And the HER2 classic is shows 3 plus HER2 on IHC or amplification on FISH, and it is otherwise negative for ER and PR. So now coming to triple negative breast cancers. This is a subtype of breast tumor which lacks either of these markers like ER, PR, HER2, all negative. It represents 15 to 25% of newly diagnosed breast cancer. Now, this TNBC is a functional term. It defines a wide spectrum of entities with different biology, clinical behaviors. There's marked genetic, transcriptional, histological difference between the tumors which come under the ambit of this term TNBC. So it's not as simple as it sounds, and it is usually characterized by a poor prognosis and lack of wide choice of therapeutics. So it's if you see in the younger women less than 40, mostly the tumors are TNBCs. The mortality rate of TNBC is quite high, especially within the first 5 years, and the relapse is highest in the first 3 to 5 years. The mortality rate is within 3 months after recurrence is as high, can be as high as 75%. And a good number, nearly 46% of TNBCs will have distant metastasis, and the median survival time after metastasis is only 13.3 months. Recurrence rate after surgery is quite high, as high as 25%. So this is all well documented. Thereby, TNBCs is considered a difficult tumor to treat and manage. So basal-like breast cancer and TNBCs, these are frequently considered synonyms, but that's not actually true. There is a lack of consensus, confusing overlap between these two terms. Now, when we say basal-like phenotype on IHC, we mean mainly by the basis of immunohistochemical markers like basal cytokeratin, CK5/6, 14, 17, EGFR, as I showed in the algorithm, and triple negativity. That's how we classify us by IHC. But with the genetic profiling studies, differences have been described between true basal-likes and other TNBCs. So basically, basal-like tumor represents majority of TNBCs, but not all basal cell tumors harbor a triple negative. So you can have a non-TNBC tumor, which may still be a basal type, but they account for the lesser percentage of cases. Now, why is it important? So this, if you do a true genomic expression and profiling, then you have true basal-like, which is the most frequent among the TNBCs, and a normal breast-like cancer, which is non-basal. So the distinction is important because basal phenotypes correlate with worse survival as compared to non-basals. They are associated with high mitotic activity, proliferation, visceral recurrences, and mostly a poor outcome. They have high genetic instability and have multiple other gene aberrations as well. And they are frequently carriers of BRCA1 mutation, approximately 20% of these basal TNBCs. So this was a sort of this thing about the basal versus TNBC. So they should not be clubbed together in a generic manner. And coming to pathological features, what we routinely see under the microscope, there's nothing very exciting that we see and we are able to tell different types of TNBCs based on morphology, because by and large, they all are very large tumors, generally high grade, have pushing or infiltrative borders, geographic necrosis. They may have a medullary phenotype, intense lymphocytic reaction, may at times be very poorly differentiated. And of course, because of that, they have high grade mitotic index and nuclear pleomorphisms. This is an example of photomicrographs of TNBCs. You can see these sheets of tumor cells separated by some fibrous septae. So if you go to the higher magnifications, these are very pleomorphic nuclei, prominent nucleoli, and a lot of pleomorphism, brisk mitotic activity, and all these features. So that's typical, and these are the kind of breast cancers we frequently see in young breast cancer patients. ER, PR, HER2/neu are negative. So it's a very bland immunohistochemistry wise. Sometimes they have dense lymphocytic infiltrate, and they are called as a medullary phenotype. And when they stain for CK5/6 and EGFR, then they are known as basal. We classify them as basal based on the IHC. So this TNBCs, even pathologically, there is not just one type. There are many other subtypes which come under the ambit of this, which can be triple negative alone sometimes. And some of them may be even AR positive, androgen receptor positive. I'll come to a little more details about this. So this is one insight on the basis of histology, which clinicians should be aware about, is that TNBCs can be both low grade and high grade. Now, when we talk of high grade, what I was been talking about all along so far, they can be invasive carcinoma NOS. They frequently have BRCA1 and TP53 mutations. Then another high grade phenotype of TNBCs is the metaplastic carcinomas, which have P53 mutation, P13K Wnt pathway alteration. And I'll be coming to some of these terms like MSL and Claudin low, etc. Then the apocrine carcinoma, in addition, shows androgen receptor expression and PIK3CA pathway mutations. And medullary phenotype I've already talked about with dense lymphocytic infiltrate. This is the immune activated type of TNBC. Now, the interesting part is that there are many tumors which are low grade and well behaved, which are also TNBCs. Now, to name a few, adenoid cystic carcinoma, which is a salivary type of tumor showing these specific MIP gene amplifications. Secretory carcinoma, same tumor also occurs in salivary glands. It shows the CTV6 NTRK3 fusion. Then you have many of the salivary tumors like mucoepidermoid, adenomyoepithelioma. They also occur in the breast and are TNBC, but low-grade tumors mostly. Then there, amongst the metaplastic, it is not that all metaplastic carcinomas, which are TNBCs, are high-grade. There can be TNBCs. Two variants are there: low-grade adenosquamous metaplastic breast carcinoma, and one is a fibromatosis like metaplastic carcinoma. They are low-grade TNBCs, and there's a new described entity which has come in the recent WHO, which is the solid papillary carcinoma, or now known as tall cell carcinoma with reverse polarity. So this shows IDH2, R172, and PIK3CA hotspot mutations, and this is also a low-grade TNBC. So there are fair varieties of TNBCs which are low-grade. So just I'll go to a little bit details about some of the important ones. Here you have the apocrine differentiation. So they have luminal androgen receptors. They show therapeutic sensitivity to P13K mTOR inhibitors. They show frequent alteration of PIK3CA pathway mutations. Immunohistochemically, they express androgen receptor positivity. Now, the correlation of androgens is a little deceptive, that some consider it has to be a better survival, while other studies have shown there is a poor survival associated with androgen receptor positivity. And this may vary with the ER positivity. Most of the ER positive tumors are also AR positive, androgen receptor positive, while same is not the true for ER negative. Medullary phenotype I've already talked. This corresponds with the intrinsic subtype. It is the immunomodulatory subtypes, which I'll be coming to a little bit later. Metaplastic carcinomas, I have already told you, there are various types. Some fit into low grade, while majority of them fit into high grade TNBCs. They show a high rate of TP53 mutations and P13K and Wnt pathway alterations. So these are, they can be spindle cell carcinomas, squamous cell carcinomas, which are high grade. Both of them are high grade. And then these two in the bottom, low grade adenosquamous and fibromatosis, like they are variants of low grade TNBCs. All of these are varieties of metaplastic carcinomas. Then some salivary gland tumors like adenoid cystic carcinomas, secretory carcinomas, they also are low grade TNBCs. So they are like salivary gland tumors, but just that they occur in the breast. And this is a newly described entity, tall cell carcinoma with reverse polarity, because the nucleus are oriented away from the lumen. They show specific mutations like IDH2R172 and PIK3CA. They are low grade, and recurrences are only in the locally in the lymph nodes. Now, another aspect of TNBCs, which is there described earliest in 2011, and then later by Lehman et al., and who later modified this in 2016, they classified these 6 subtypes of based upon the analysis of 21 breast cancer data sets. Later on in 2016, they did a PAM50 analysis of the same subsets and narrowed down from 6 to these 4 classes. So what are these? These are the basal-like 1, basal-like 2, immunomodulatory, mesenchymal stem cell-like, and luminal androgen receptor. But it was found that these 3 pertain to stromal characteristics and the inflammatory cells within them. So they were all clubbed together in mesenchymal subtype. Now, each one of these basal-like 1 has a morphology. Pathologically, they look like IDC-NOS. Basal-like 2 also looks like that. Immunomodulatory, because it is rich in lymphocytes, it looks like the medullary phenotype. While mesenchymal stem cell like, it is metaplastic. Now, all of them have specific, genes which are expressed in this. So I've listed those here. In 2015, Burstein et al. Also did a DNA sequencing and RNA sequencing. So they did a genomic data as well as transcriptomic analysis. And this original classification by Lehman et al. Was they reclassified them as basal-like immune-associated, basal-like activated, basal-like immune-suppressed, luminal androgen, and mesenchymal subtypes. So these were described by Burstein et al. And then this was this FUSCC classification from Shanghai, Fudan University, Shanghai classification, which classified them into these 4 classes. So various subtypes, and why these classifications were made based on the genes expressed, the cycles or pathways which were activated. Based on that, these classifications emerged. So this is the evolution of the classification of TNBCs. These are the original Lehman 6 subtypes, which were narrowed down to 4 subtypes by Burstein et al., as well as Lehman et al. In 2016. And this FUSCC classification also has these 4 subtypes. Now, if you notice this difference in color, so all these subtypes, it's not that they are sacrosanct. So there is an overlap of each of these subtypes, but depending on which subtype is dominant, which gene set of genes is dominantly expressed, these are classified into these classes. So lymphocytes has an important role nowadays in breast cancer reporting. In fact, in our pathology reports, we mentioned whether the TIL high or a TIL low tumor, because it has been shown. Now there is a TIL working group which has classified and given guidelines for how to report TILs, because a high TIL is associated with better prognosis, and it has also a connotation for immunotherapy. So PD-L1, as you know, and PD-1 and PD-L1, so anti-PD-L1 drugs are available. So approximately 20 to 50% of all TNBC express PD-L1. So there have been these 2 drugs, pembrolizumab and atezolizumab, but this has been withdrawn now, and but pembrolizumab is still being used, and there is a companion diagnostic for it, which is the DACO DC23. So we do what is known as a CPS score, and there is a formula to calculate that, the number of positive membranous staining tumor cells. So you, as a pathologist, you have to follow report PD-L1 scoring based upon a specific companion diagnostic test and accurate counting of the correctly stained cells, and arrived at this formula and give a score depending on which a patient is eligible for treatment for anti-PD-L1 drug or not. Now, metastasis is another feature which is, and about TNBC peculiar is that it has frequent visceral metastasis, unlike other breast cancers. So to the pleura, lung, bone, it can metastasize. People have identified immunoregulatory gene signatures which are suitable, which can predict whether a TNBC. So this is one of those signatures, AR negative, ER beta positive, and P53, which is associated with the decreased overall survival of these metastatic TNBCs. Now, I'll just kind of not go into too many details over the next few slides which I have, which are more of molecular targets. As you know, people have developed a lot of molecular targets as depicted in this study. So now the importance of this, what I was talking about, the basal like 1, 2 immunomodulatory mesenchymal. So there are therapeutic strategies which have been designed based upon the pathways which are activated in each of these subtypes. So as you can see, there are therapeutic targeted drugs like mitotic inhibitor. For example, basal like 1, you are all aware that PARP inhibitors are very frequently used. Basal like 2 also PARP inhibitors, and growth factor inhibitors are more important, mTOR inhibitors. In immunomodulatory pathway, this is where your anti-PD-L1 and all will be very useful along with other cytotoxic drugs. Then mesenchymal type, where growth factor inhibitors, mTOR inhibitors, P13K inhibitors like drugs are used. And you have the mesenchymal stem cell like. So there are various targets. Many of these targets are being tried. There are clinical trials which are going on. So very few targets are actually approved for use in clinical practice. And then you have the luminal androgen receptor, which showed a lot of promise initially, but kind of only around 10% of breast TNBCs, they are really where you will find these useful. So this is just a few more details about this. So as I already told you, DACO22C3 is the companion diagnostic for this drug. And then you have other targets. So these are immune checkpoint modulators. So PDL1 is one, then CTLA4 is another, lymphocyte activated gene 3, T cell immunoglobulin, hedgehog and neuropilin 2 signaling pathway. These are all immune checkpoint modulators, of which the first one, which I have listed here, has been approved. Then you have targets within the nucleus like BRCA1 and BRCA2 for you have platinum-based therapy, the PARP inhibitors like olaparib. And then these are other targets like histone deacetylase, P53, checkpoint kinase 1, and DNA binding agents like mitramycin. Then you have the intracellular and signaling mediators like androgen receptors, you have the enzalutamide, then heat shock proteins, cyclin dependent kinases. So P13K, then mTOR pathway targets like everolimus and all. So there are various targets which are there. Then you have the cell surface targets like VGFR2, EGFR, fibroblast growth factor, trophoblast antigen 2. I'll talk a little bit about this TROP2. This is a transmembrane glycoprotein encoded by this gene. It is an intracellular calcium signal transducer that is differentially expressed in many cancers. And it signals for self-renewable proliferation and invasion, has stem cell-like qualities, and it is expressed in many normal tissue. So that's why, when you have an antibody directed against it, then it may also harm the normal cells. Therefore, you have to target only the cancer cells. So this strategy has been evolved. You may be aware about this drug, Trodelvy. So this is actually sacituzumab govitecan and HZIY. This is actually an antibody drug conjugate, which is an immune targeted therapy. Now, the purpose of this conjugate is that it should not harm the normal cells. So this is the drug, and then SN38, a topoisomerase I inhibitor chemotherapy is used, and a compound that links this sacituzumab to the SN38. It is designed to deliver SN38 chemotherapy to cancer cells in a targeted way by attaching the SN38 to the sacituzumab. So this is one of the drugs. So I've just kind of tried to cover most of the drugs which are in use and which are currently being in clinical trials or at experimental stage, which may be future targets, because as we mentioned in the very beginning of our session that TNBC is a very difficult to treat because there are very fewer targets. So a lot of work is being going on all over the world to meet the target. So it's a heterogeneous and integrated family of cancers. Major part show high pathological grades and high rate of proliferation. There is so good response to chemotherapy with cytotoxic based drugs. Now, genomic profiling techniques have not, nowadays it's becoming easier to do those. So they open a newer frontier for comprehension of TNBC biology, not only biology, but also provide prognostic and predictive data, what drugs to choose. So histology diagnosis is not enough to, reproduce the intrinsic subtypes. So, and as clinicians, I already showed in one slide that you should be aware that not all TNBCs are bad. There are low-grade subtypes of TNBCs where you should avoid over treatment. So with that, I'll end my talk. Thank you very much.
Thank you, Sandeep sir, for enlightening such an enlightening talk. Now I would like to hand over the proceedings to Dr. Chirag. Welcome, Dr. Chirag.
Good evening. Thank you, Sandeep sir. That was a very in-depth understanding of the pathology of TNBCs that you have given us, and giving us so many targets and then telling us that there are not many targets in TNBC. So next we would be talking about immune checkpoint inhibitors, about which Dr. Sandeep sir has already thrown some light. And I think with all the buzz surrounding immunotherapy these days, especially in the last couple of days, people talking so much about dostarlimab doing wonders in CA rectum. And this webinar would be incomplete if we don't talk about ICIs in TNBC. So we do understand that TNBC is characterized by relatively high tumor mutational burden compared to other types of breast cancer, and which is why it is more responsive to immune checkpoint inhibitors. And also we know something about pembrolizumab being used in stage 2 and 3 TNBCs, being established as a standard of care. So to talk further on this topic, we have with us Dr. Venkat Pradeep Babu, a very dear friend who is currently Senior Consultant Medical Oncology at Assam Cancer Care Foundation, Tezpur. Any questions from the audience would also be welcome and may please be posted in the Q&A column. Over to you, Dr. Venkat.
Thank you, Dr. Chirag. First of all, I want to thank Arun sir, Dr. Chirag Jain, my dear friend, and Vaishali ma'am for involving me in this August gathering for talking about immunotherapy in triple-negative breast cancer. Chirag, can you hear me clearly?
Yes, you are very clear.
Yeah, thank you. The topic given to me is about immunotherapy in triple-negative breast cancer. Have they arrived? So a long story in a very short fashion. The story of immunotherapy in breast cancer, particularly in triple-negative breast cancer, it is about the story of pharma industry, the logic and the magic of the biostatistics, the hype around the hope of the cancer, debates, discussions, withdrawals of the approvals, and persistent hope that always hovers around the cancer. As my friend has mentioned about dostarlimab, every oncologist and every associated person in the cancer hospital received message about the dostarlimab for the last 2 to 3 days. And coincidentally, this is also one of the drugs that is immunotherapy approved in triple-negative breast cancer. And let's discuss about this. And triple-negative breast cancer, it is one of those few cancers which carries a lot of negativity in the name itself. And it is equally ominous as it sounds in the prognosis. When we see briefly the incidence of triple-negative breast cancer across the globe, it nearly accounts for 10 to 20% of all the breast cancer cases across the globe. But in India, it accounts for more percentage, from 27 to 34%, and nearly half of these cases they present in stage 4. The most worrying part about this presentation in India is the minimum age spans to nearly 22 years, which is half the age at which we start the screening for the breast cancer. And the maximum age is 75 years, which is not really high. And more than 60% of patients, they are less than 50 years. That means in the most productive age of their life. The median age of presentation in India is nearly 49 years. So how TNBC is different from other subtypes of breast cancer? The molecular aspects and pathological aspects are very well covered by my previous speaker, Dr. Sandeep. And when we see the clinical characteristics, how it is different from the other subtypes of breast cancer, most of them, they are high grade, usually grade 3, and they present as a larger aggressive tumors at the time of diagnosis. And we know that even though they respond very nicely initially, they have very high rates of recurrence, more aggressive disease with a higher mortality rates. When we see the clinical outlook of a patient with TNBC treated with the best care that is available as of now, the median survival for a woman with metastatic TNBC is less than 1 year from the Indian statistics. And when we compare with the other subsets, it is quite less and dismal compared to the HER2 positive and hormone positive subsets. And we also all are aware that they metastasize to lungs and brains more commonly than to the bone, like hormone positive subsets. When we see these graphs here, we can clearly see that the stage 3-4 TNBC fares much poorer than the other subsets, accounting for only 30% 5-year survival rates, contrary to the nearly double the survival rate in the other subsets. So we clearly now understand that treatment options are limited and posing a high unmet clinical need in this setting. So what are the efforts that are done to optimize the outcomes in this aggressive TNBC, particularly in advanced stage? So globally, there were so many trials, and till few years ago, this is the treatment algorithm we all have followed, mainly including the chemotherapeutic drugs, the taxanes, the platinums, capecitabine, and eribulin. And hardly after these drugs, we have only best supportive care left. But with all the efforts, now we have started understanding the triple negative breast cancer better. And when we give all the neoadjuvant chemotherapy earlier, and when there is a residual disease after resection, we can give capecitabine, which showed the survival benefit. And with the better understanding of the genetics, we have PARP inhibitors in place and targeted therapies like saxatrozumab govitecan, just like Dr. Sandeep Madhur has really elucidated. But are the efforts enough to tackle such an aggressive cancer? No. So how to tackle such a formidable enemy? The only way to understand, to tackle the cancer is by better understanding it. We cannot actually try each and every drug. Only when we delve into the molecular genetics and molecular subtypes of the breast cancer and triple negative breast cancer, will be able to tackle it. So these are the 4 subtypes of molecular subtypes of triple negative breast cancer. We understand from Dr. Sandeep's presentation, there are so many, so much of evolution that has taken place in the biological subtypes, molecular subtypes of triple negative breast cancer. But these subtypes are based upon the studying of the pathways and the types of the molecules that are expressed, genes that are expressed in the tumor cells. But sometimes we are so close to the trees that we lose the sight of the forest. We also know that tumor microenvironment is equally important as the cancer cell to understand it better. This is the picture I have taken from MD Anderson website. And we can see here the tumor microenvironment. It is composed of so many cells that infiltrates the tumor and forms the tumor microenvironment itself. We can see the natural killer cells, the monocytes, the lymphocytes, the adipocytes, and the fibroblasts. Some of them helps our own immune system to tackle the growth of the cancer, whereas some of them, they are the inhibitors, and they actually associate and encourage the development of the tumor. So by the composition of these cells, the tumors are divided into immunologically cold tumors and immunologically hot tumors. And when the immune suppressing cells predominantly form the tumor microenvironment, it is called as immunologically cold tumor. And when the cells that are active and fights against the cancer cells, like the T cells, CD4 cells, CD8 cells, when they are more in the tumor microenvironment, they are referred to as immunologically hot tumors. But we should remember that although TNBC are immunologically active because of the very high proliferation rate and a high amount of tumor mutation burden, not all TNBCs are the immunologically hot tumors. So within when we incorporate this microenvironment in the classification of the TNBCs, There are three types of TNBCs that are seen. The type 1 is called immune desert type, which means there are no tumor infiltrating lymphocytes or the tumor infiltrating cells that are present in this type, and so they are usually resistant to the immunotherapies. Type 2 are called cold tumor, which are innate immune activated, but the predominant cells are tumor inhibitory type. And when we see the hot tumor, they are the immune inflammatory type, where they are the active cells fighting against the cancer. Before going to see the approved drugs of the immunotherapy in TNBC, let us see a bit about how immune system tackles the cancer. There are three phases in which a immune system can encounter any change, any carcinogenic change in our body. So we all know that we are all susceptible to cancer because of the DNA damage that occurs regularly on a daily basis. Nearly 10,000 DNA mutations occur in all of us per day, and our immune system is well equipped to tackle all these changes. And whenever there is a change that is carcinogenic or the new aberration that is happened, usually these cells infiltrate and detect this change and eliminate those cells to prevent any carcinogenesis. This phase is called immune elimination, and this is what happens in all the normal population like us. And whenever the tumors find out a way to find an equilibrium between the infiltration of these cells, and they are able to survive with the more and more development of genetic mutations and aberrations, which will help them to masquerade from the immune system. The stage is called immune equilibrium. And with the more amount of mutations and better escape from the immune system, the tumor starts to grow even in the presence of the immune cells. This is called as immune escape stage. And this is what we see as a frank tumors. And in all those patients who are having the progressive tumors or developed growing tumors, it is this phase we actually see, immune escape stage. So what is immunotherapy? So any treatment that helps our immune system gain the ability to fight against the cancer is the immune therapy. And it includes both the active immunotherapy as well as the passive immunotherapy. What is active immunotherapy? When we involve the living cells as such, like adaptive T cell transfer and chimeric antigen receptor T cell therapies, this is called active immunotherapy. And passive immunotherapies are those like monoclonal antibodies, which actually receives the mask of the masquerading of the cancer cells from the immune system, like checkpoint inhibitors, which are the only available immunotherapies as of now in India for the solid cancers, and vaccines, etc. The PD-L1 pathway is very well studied, and it is the one pathway that downregulates the anti-cancer immune response at two different levels. So what is PD-L1 pathway? So whenever the immune cell has to detect the cancer cell, it has to bind with the two receptors. One is with the MHC complex, other is with the CTLA4 antigen. However, when the tumor cell expresses the PD1 or PD-L1 antigen, the receptor, and it binds to the T cell become inactive, and it actually cannot act on the tumor cell. It is how the tumor cell escapes and proliferates in the presence of the T cell. So why TNBC is considered as a very potential subset of immunotherapy? When we see the lot of trials that are happening in breast cancer, majority of the immunotherapy trials, they occur in TNBC. Why is so? Because the mutation rate of TNBC is quite high when compared to the other subsets of the breast cancer. The mutation rate is estimated to be nearly 13 times the normal cells. And whenever there is a abnormal mutation, there are new antigens that are produced and are expressed on the cells. And when there are expression of the new antigens on the cell surface or within the nuclear or cytoplasm, the immune cell actually can detect and act upon them. Also, TNBC is the one subset where there is a lot of T cell infiltration, which is clearly described by my previous speaker. It is an essential precursor for any anti-tumor immune response. Only when the cells are present in the tumor microenvironment, the CPIs are thought to be effective. And when we see here, the T cell infiltration is quite high in TNBC when compared to the other subsets like hormone positive and HER2 positive subset, where we can see nearly 30% of TNBCs, they have high TILS infiltration. Also, we can see the half of the TNBCs, they express the PD-L1, and so they actually effectively escape from the immune action from killing them and inhibiting their proliferation. So before discussing the drugs, are there any effective biomarkers based upon which we can select the particular tumors who might respond to immunotherapy? The most well-studied biomarker is PD-L1, although it is very much imperfect because it is the only one that is available, so it is well-studied. But PD-L1 is not a single marker that is actually reported. Just like Dr. Sandeep Madhur has illustrated, there are so many nomenclatures that are used based upon the type of PD-L1 and which cell we are studying. So if we report the PD-L1 report from the tumor cells, it is called a tumor score. If it is reported only from the immune cell, it is called immune score. And when we combine the PD-L1 expression both from the tumor cells and the infiltrating immune cells, it is called as combined proportion score. Why should we know this? Because only when we know this, we can order the appropriate test, because all the immunotherapies, they are based upon the companion diagnostics, and so we have to use only those tests. Like if we have to use the pembrolizumab, we have to use the CPS score. What are the other biomarkers along with the PD-L1? Mismatch repair genes mutations, or we can see microsatellite instability. So these are the genes, these are the proteins actually which will repair the DNA abnormalities, and the genes encoding these proteins, when they are mutated, there are abnormally high amount of the production of the neoantigens, which actually attracts the T cells to infiltrate the tumors. And so MSI high is a marker for the immunotherapy, particularly checkpoint inhibitors, to act. The other factor, the other biomarker that is well studied is tumor mutation burden. It is well studied in lung cancer. It is also being studied in breast cancer. So what is tumor mutation burden? So we know that cancer has more number of mutations compared to the normal cell. And when any cancer exhibits the more number of mutations, particular per megabase, that is per DNA megabase, with the length of the DNA which we measure in megabase. If the number of mutations are greater than 10 per megabase, we call it as a higher tumor mutation burden. And if the TMB is high, there is a more chance of immunotherapy action in these cancers. So we have discussed so much of the theory. So what is the data in reality? So first of all, let's see the immunotherapy in advanced triple-negative breast cancer. As of now, to date, these are the approvals that are given for the immunotherapy in advanced breast cancer, including all the subsets. When we see the TNBC, the approval is for the pembrolizumab plus chemotherapy, which is category 1 recommendation, in combination with chemotherapy, which can be nab-paclitaxel or paclitaxel or gemcitabine and carboplatin combination. So what is the biomarker they have used? It is a combined positive score greater than 10, which we have already discussed. In the same way, pembrolizumab is also approved when MSI or DMMR is, when microsatellite instability is high, or when there is a defective mismatch repair genes that are detected by IHC. So pembrolizumab can be used in this setting when we adjust all the standard options. Also in the same setting, our most discussed drug for the last 2 days, dostarlimab, is also approved. And when TMB is high, that is greater than 10 mutations for MB, pembrolizumab can be used in this setting also. When we see the evolution of the immunotherapy in metastatic triple-negative breast cancer, these are the very early trials which have shown nearly that 1/4 of the responses of all the 100 patients tried, only 24% of the patients have responses. And we can see here, as we move on to the first line to the second line, the response decreased dramatically. And greater than second line, we can see the response are as low as 5 to 6%, which we can actually get with metronomic therapies also. So pembrolizumab versus chemotherapy in second and third line. This is the Keynote 119 study. What they want to assess is whether in the second and third line, pembrolizumab can achieve a better survival compared to the chemotherapy like eribulin, capecitabine, or other chemotherapy of investigator choice. The primary endpoint they want to look at is CPS1 greater than 1 and CPS greater than 10. If CPS greater than 10 is achieving a greater result of immunotherapy than 1. But this is a failed trial. This is a failure where they have seen that CPS 1 and CPS greater than 10 have not achieved any good response compared to the other chemotherapy of the choice. But in an exploratory analysis, they have found that CPS greater than 20 has achieved a better result. But we all know that any unplanned analysis should be taken with a pinch of salt, and so this is considered as a failure. Compared to the other hype drug, atezolizumab plus chemotherapy in triple negative breast cancer. So this is IM Passion 130 study. IM Passion 130 has shown a better performance where the first interim OS analysis is really hopeful, and it was shown that HR rate of 0.62 and preventing nearly 38% of the events in PDL1 positive population. We can see the curves getting well separated here. And based upon this data on interim OS, it received accelerated approval by FDA that atezolizumab plus nab-paclitaxel can be used in metastatic TNBC based upon this preliminary data. However, based upon the IM Passion 131 trial, it was seen that the OS is not different from the other arm, the platinum and taxane arm. So just like the hype that is being created about the dostarlimab, seeing the abstract and getting excited is not a real thing. We should not do that. And by the time the exact results and the test of time takes place after a few years, the entire result may be different. So final OS analysis has shown to fail to show benefit in IM Passion 131. And so in US, and followed by in India, the atezolizumab indication was withdrawn from the metastatic triple negative breast cancer. We all know this is what happens whenever a costly drug is being tried in clinical trials. So statisticians, they tried the level best, and we can see several sentences stating that although it is not statistically significant, there is a clinically meaningful benefit that is observed, which is actually very difficult to understand. So accelerated approvals in oncology, is it a boon or bane? We don't know, because these are the tweets that we can see raising a lot of enthusiasm and discussion across the globe when it is initially approved in 2019, but later on after 2 years, we can see there a lot of nihilism surrounding again and the comments coming upon withdrawal by the Tecentriq, that is atezolizumab, from the market. So leaving aside the negativity of the triple negative breast cancer, what are the drugs that actually we can use, and what are the data based upon the current approvals? So we have seen this based upon the CPS, MSI, and TMB. And also this is the current NCCN guidelines, which do approve pembrolizumab plus chemotherapy in metastatic triple negative breast cancer. Also pembrolizumab as a single agent, either 3 weekly or once in 6 weekly at a 400 mg dose. So the trial that is responsible for the approval of pembrolizumab plus chemotherapy is Keynote 355, where pembrolizumab plus paclitaxel and carboplatin is compared with the placebo and chemotherapy. The primary endpoint is PFS and OS, and we can see that in this subset of combined proportion score greater than 10, it has achieved its primary endpoint, and so it is approved based upon the overall survival result, which is the key factor which we all as an oncologist look at whenever we are using any drug. And particularly,
Dr. Venkat, sorry to interrupt. You're behind schedule. How many slides you have?
Yeah, I am able to complete, Dr.
Okay,
Shiva. So coming to the immunotherapy strategies in early breast cancer, the immune environment in early triple negative breast cancer is different from the metastatic triple negative breast cancer. So it is found that the better immune environment to fight the cancer is found in early TNBC compared to metastatic TNBC. And this phenomena is called immune phenotypic shifting. So coming to the approval of immunotherapy in early TNBC, it is pembrolizumab plus chemotherapy followed by pembrolizumab in the adjuvant setting for 8 to 9 cycles, and the study responsible is Keynote 522. And the main parameter that was seen in this study is about the better EFS with the pembrolizumab compared to the. So based upon the better EFS rates, it got approved. And there are some other trials that are going on in the early TNBC. These are all the trials, predominantly involving the pembrolizumab and etidolalimab. So these are the new biomarkers that are being tried in the TNBC trials, that is circulating tumor DNA, TILs, alteration in the PDL1 encoding gene, MHC1 loss. And as of now, as an oncologist, we all know that whether we have to use this drug or that drug is an illusion, and case to by case basis, we all know what we have to do. Thank you so much.
Thank you, Dr. Venkat. There's a reason why we used to call you an encyclopedia. So that we can see from your presentation. We have a question from Dr. Suresh Sancheti here. What tumor markers available in India are usually used, and at what time these tests are to be asked for? At the presentation, after treatment, or during clinical relapse? Would you like to throw some light on this?
Tumor markers for immunotherapy.
Yes. Yes.
So the tumor, there are no specific tumor markers that are approved for assessing the response in the immunotherapy as such. But there are very small studies where they say that CRP, beta-2 microglobulin, we can follow up, but they are not approved in the current standard of care. So there are no tumor markers as such to see whether the patient will respond to immunotherapy or not. Only those biomarkers that are already discussed are approved.
Thank you, Dr. Venkat. That was a very nice presentation. Over to you, Dr. Safalta ma'am, for the next talk.
Thank you, Dr. Chirag. With the invention of PARP inhibitors, it made a paradigm shift in management of TNBC. But whether to give it to all patients and when to give, when to do the BRCA testing, what is HRR, what is HRD, which PARP inhibitor to give. All these questions will be answered by Dr. Samya, who is professor and head in the Department of Medical Oncology in IMS and some hospital, Bhubaneswar. Welcome, Dr. Panda.
Thank you, madam. Thank you, ma'am. Can you please share my slides? Thank you. I think this is a very important topic, as important as the immuno-oncologists who are the PARP inhibitors in triple negative breast cancer. So I'll discuss on the role of PARP inhibitors in triple negative breast cancer. Next slide, please. So the prevalence of BRCA1/2 mutations in breast cancer in unselected population of breast cancer, the incidence is 5%. And if we look at TNBC subset, then it is as high as 17%. And the hormone receptor positive, it is around 6%. And the difference is that in triple negative breast cancer, most of the patients have a BRCA1 mutation, while in hormone receptor positive, majority are BRCA2 mutation. So this is one very important point. And the variability is a lot unlike ovarian cancer. So we need to bring out our own data. So we studied in our own population that are visiting to our OPD. Next. So this is our institute data. We found out that it was 14.28%, which we presented in our TMH Women's Cancer Initiative conference. And that was around 40 patients we had tested for a BRCA mutations. Surprisingly, again, like ovary, hardly 10% of the patients had a family history. So that brings into a very important point. So even if the family history is absent, if it is a triple negative breast cancer, then better to do a BRCA gene mutations because of multiple implications in adjuvant as well as in metastatic setting. Next slide, please. So whom to test for BRCA? So in as per the ESMO guidelines, if you look, it is a strong family history of breast, ovarian, pancreatic, or a high-grade metastatic prostate cancer, or there is a diagnosis of breast cancer before the age of 50, or a triple negative breast cancer less than 60 years, and a personal history of ovarian cancer or second breast cancer or a male breast cancer. So in short, if it is an early breast cancer, then you have to have some high-grade character or some different characteristics like strong family history. It is a triple negative breast, patient has got a male breast cancer or a family history of ovarian cancer. So these characteristics along with early breast cancer, you have to do that. In metastatic breast cancer, whoever is HER2 negative, then you have to go over with a testing for a BRCA. So this one is in the nutshell. If you look to the NCCN guidelines, again, patients who have been having a history of a known variant of a BRCA in the family, or a personal history that is again young, less than 45 years, 46 to 60 with family history. So across all ESMO and NCCN, the guidelines looks pretty similar. So any triple negative less than 60 years, better to do a BRCA genetic testing. And if a therapeutic target is there, then in the St. Gallen's it was discussed whether they would like to go ahead with a testing. Answer was that around 80% they would like to go ahead. And if you have got a drug for that, for patients who are, if we prove that tomorrow that the BRIP1, the CHEK2, the NBM, and the BARD1, PALP2. So these are other mutations like in prostate. If you have got a therapy and it is proven, then would you like to go ahead? Answer was yes. So St. Gallen's gave a very important point that besides the BRCA, if we can prove that it is benefiting the other part also, like in ovary we have seen that. So if there is a benefit, then definitely they would like to go ahead with testing that. However, having said that, right now it is only BRCA1 and BRCA2. Next slide. So this is what I was alluding to. Germline testing, whom to test, early stage with additional criteria like younger age, family history, male gender and personal cancer history. And in metastatic, if it is HER2 negative, then definitely go out to the BRCA testing. Next slide. So the discussion like germline BRCA or a paraffin block, the T-BRCA, or a HRR gene panel, or a HRD. So right now, we agree, all of us agree that germline BRCA is the one which we will do definitely in our clinics tomorrow. But looking at the T-BRCA, HRR and HRD, we will not be surprised in future if the indications come. But right now we should restrict ourselves to the germline BRCA. Next slide. So patients with BRCA mutant early breast cancer have distinct tumor characteristics compared to the sporadic population. Unlike ovary, where they are more platinum sensitive, the outcome is good. It may not be the same in the breast cancer. So mutant BRCA breast cancer may be more aggressive phenotype compared to a sporadic. So patients are diagnosed at a younger age. They are of higher grade. More of CNS metastasis might be there. More contralateral and ipsilateral disease is there, and they might have a higher risk of recurrence. So we have to be very careful while dealing with a BRCA mutant breast cancer. Unlike ovary, whom the outcome is better because of the platinum sensitivity. Next slide, please. So coming to the PARP inhibitors, the mechanism of action. So it is a basic oncology which we had learned during our studies, that the PARP inhibitor acts by mechanism of synthetic lethality. So PARP inhibitor, PARP enzyme that works in the single nucleotide repair, while the BRCA that is that helps in the double stranded repair. So if your BRCA is mutated, then your double stranded repair is defunct, and that cell tries to repair it through the single stranded pathway, but then again you are blocking it through the PARP inhibitor. So this is known as synthetic lethality in a BRCA mutant breast cancer. Next slide, please. So coming to the indications where you will use. So in non-metastatic, it is used in neoadjuvant and adjuvant. So in the neoadjuvant, we have the data of talazoparib, then the brightness data of beliparib and platinum, and then in adjuvant, the very important Olympia trial. In metastatic, the Olympiad had shown that olaparib is a very good option, and Brocade 3, Embraca, and Ruby. These are the trials that look into the PARP inhibitors in metastatic breast cancer. Next slide. So this is the neoadjuvant talazoparib for patients with operable breast cancer with a germline BRCA pathogenic variant. This came out in JCO in 2019, and 20 patients, they were given talazoparib 1 milligram per day for 6 cycles. So you have given a tablet of talazoparib 1 milligram, and then the surgery was done, and then they looked at the residual cancer burden, that is the RCB. So how many patients achieved? So around 12 patients achieved a RCB of 0 or 1, which we consider a good response. So PCR response was 53%. So that showed that a single tablet of talazoparib is showing a very good response, and this is a chemo-free area. So patients who are BRCA mutant, if you give them a talazoparib, then the responses are good. However, having said that, the number of sample size is 20. This provides a hypothesis for a bigger study. Next slide. This is again the NeoTala trial. NeoTala trial, the number of patients 61, again by the same authors, and then the outcomes. Then the outcome in neoadjuvant, as we look at the PCR, again the PCR rates were good. It is something like 47%. So this was a very good PCR rates, and the treatment-related adverse event again was manageable. Next slide. So after the data of the single agent PARP inhibitor, then comes the data for the combination beliparib plus carboplatin or carboplatin alone to a neoadjuvant. So neoadjuvant was paclitaxel. So whether we'll go ahead with only single agent paclitaxel, or we'll go ahead with the pacli plus carbo, or whether we'll go ahead with the pacli plus carbo plus beliparib. So this was the design of the trial, 2:1:1 randomization. Good number of patients, 634 patients, and then they were randomized accordingly. And those were patients, they were given Paclitaxel carbo or Veliparib. They were given again a complete of adriamycin and cyclophosphamide, and then the surgery was done. This is what we do in our practice, that Paclitaxel will be there and adriamycin cyclophosphamide will be there, and then surgery will be there. Only thing that carboplatin and Veliparib was looked into. Next slide. The primary endpoint of the trial was a PCR. Unfortunately, this particular trial did not show that addition of Veliparib is giving a better PCR compared to addition of only carboplatin. So Paclitaxel, if you get a PCR, then the Paclitaxel plus carboplatin is getting a better PCR. But whether addition of Veliparib is improving your PCR, answer was no. So addition of Veliparib did not impact PCR. But what this trial showed that the carboplatin was improving your PCR in spite of only Paclitaxel. So this reinforced that as a neoadjuvant setting, you can add carboplatin in your patient. Next slide. So these were some other trials. These are the neoadjuvant in the neoadjuvant setting, like I-SPY 2, brightness. Then we've got Jeparola, partner. So some of the trials, they're all phase 2 trials, and some are phase 1 trial, and some are phase 2 and phase 3. So you don't have a phase 3 data as of now to establish this neoadjuvant PARP inhibitor is there in your clinic tomorrow. Next slide. So summary of the neoadjuvant PARP inhibitor plus chemotherapy or PARP inhibitor alone. Next slide. So answer is that tomorrow we are not using that, but as per the data, definitely it is a very emerging area. Both PARP inhibitor alone and PARP inhibitor plus chemotherapy, some results are there. Despite that, it is not very enthusiastic to use it in a routine practice as of now. Next slide. So this is a very important trial of adjuvant data of Olympia. This was a phase 3 study of olaparib versus placebo as an adjuvant treatment for high risk germline BRCA mutated HER2 negative breast cancer. So we had got patients who were stage 2 and stage 3, and then there was a very clear-cut stratification of a high risk, selecting out the high risk group. How it was selected? In a neoadjuvant setting, if the TNBC is not achieving a PCR, and if it is a hormone receptor positive, then a non-PCR plus CPS EG score more than or equal to 3. In adjuvant, again TNBC, it is more than or equal to pathological T2 or anything more than or equal to PN1, and hormone receptive, this was a more than or equal to 4 positive lymph nodes. So why did they stratify like this? Because they wanted to see that these are the high risk groups and they are having more of events, and that is why you will get a positive results. There is no harm in doing that. So very well conducted and well designed study that selecting out a patient who is having a high risk. So TNBC, if we focus non-PCR in neoadjuvant, and in adjuvant, TNBC was more than or equal to PT2 or more than or equal to PN1. And then the randomization was done at olaparib or a placebo. Patients have already completed minimum of 6 cycles of neoadjuvant or adjuvant chemotherapy of anthracycline and or taxanes, and then they have completed surgery, they have completed RT. So this is what the routine practice is. And then instead of keeping them on follow-up, you give them olaparib 300 mg twice a day. This was only selected pathogenic mutations of germline BRCA1 and BRCA2, and was the primary endpoint IDFS, and the key secondary endpoint distant disease-free survival and overall survival. Next slide. So if we look at the data, the hazard ratio was 0.558. So after 3 years, your IDFS, it is 85.9% in the interventional arm compared to 77.1% in your placebo arm. So definitely there was a very nice improvement of around 8.8% of IDFS. Next slide. So whether this was on particular subgroup, answer was that no. Across all the subgroup, your olaparib is being favored. So be it adjuvant or neoadjuvant, whether patient has received platinum or not, whether patient is hormone receptor positive or TNBC, whether BRCA1, BRCA2, across all the subgroups, there is a consistent improvement of the consistent benefit was seen across all the IDFS subgroups. Next slide. So 87.5% of the patients treated with adjuvant olaparib were free of distant recurrence or death at 3 years. Not only that, IDFS, even the DDFS was improved, and the hazard ratio was again very strong, 0.57. Next slide. So again, the questions were raised that whether there is a OS improvement or not. So the OS improvement, it was definitely there. The recent 4-year update has come, and again the hazard ratio is 0.65, and the p-value is 0.09, and it has crossed the significance boundary of 0.015. So as per the latest data, there is a significant OS improvement as well. Next slide. So the difference of 4-year OS rate was 4%. Coming to the adverse event, whether the drug was manageable or not, as per the trials, we have used olaparib in ovarian cancer, and the nausea, fatigue, anemia, and vomiting, they were there, but they were all manageable. So grade 3 and grade 4 events were a kind of 24% versus 11%, but there was all manageable. And grade 4 adverse event 1.9 versus 0.4. So it was a manageable, and discontinuation rate was hardly less than 10%. Next slide. So Olympia summary was that FDA approved the olaparib for adjuvant treatment of patients who were germline BRCA mutant and HER2 negative in high risk early breast cancer who have been treated with chemotherapy and surgery and RT. Next slide. So it was definitely yes in the adjuvant setting. So coming to the advanced breast cancer. Next slide. So this is the Olympiad study. Again, this is a patients who are metastatic breast cancer or advanced breast cancer, and they were germline BRCA mutant, and prior chemotherapy of anthracycline and taxane has been given. And we know that this is a very bad population, triple negative breast cancer, whom you have already deprived of anthracycline and taxane. You hardly have capivasertib, eribulin, and vinorelbine in your armamentarium, and already there was the comparator arm. So you are comparing with something standard or versus olaparib 300 mg twice a day. And the primary endpoint was a PFS. Next slide. So the median of PFS 7 months versus 4.2 months, at the hazard ratio of 0.58, and there are some patients who do good for a long time even. So the PFS at 12 months was 25.9 versus 15 months. Next slide. Again, coming to the secondary endpoint of OS. So the OS that was hazard ratio of 0.90. But if you look at the patients who have not received the prior chemotherapy, then the hazard ratio is 0.51. So that sends a signal that you use it early. So definitely a PFS benefit is there. OS, there was only 64% maturity, and at that time the OS is not significant. But if no prior chemotherapy, early usage is there, then definitely it is a wonderful drug. Next slide. So coming to the EMBRACA study, this was the other study of Olympiad was olaparib. This was talazoparib versus chemotherapy in advanced breast cancer. Next slide. So again, EMBRACA showed that talazoparib again is a very good drug in this setting. Patients who are germline BRCA mutant, the 1-year PFS in the EMBRACA study was 37% versus 20% in the standard chemotherapy arm. Next slide. So this is a Brocade 3 veliparib plus paclitaxel for patients who are having advanced HER2 negative breast cancer with a germline BRCA 1 and 2 mutation. The primary endpoint was met with the investigator PFS significantly improved with veliparib versus placebo at the p-value of 0.02, and 36 months PFS was 26% versus 11%. So you have got the options of olaparib, you've got the option of talazoparib, and you have got the option of veliparib plus carboplatin. Next slide. This is the rucaparib being available now. So Ruby trial, a phase 2 study testing rucaparib in germline BRCA wild type patients present with metastatic breast cancer with homologous recombination deficiency. Next slide. So this was based on the LOH score. So this is again a very important trial looking at the ovarian data. So the patients who had a HRD deficiency, a phase 2 study that tested rucaparib in germline BRCA mutant, and they had a homologous recombination deficiency. So next slide. So coming to the ESMO clinical picture practice for guideline for diagnosis, staging, and treatment of patients with metastatic breast cancer. So you see the right on the top, PDL1, you have got immuno-oncology, but germline BRCA mutant, then definitely a PARP inhibitor is right there on the top. So that is a very, next slide. That is a very definitely a yes in metastatic setting in TNBC. New questions to be answered post neoadjuvant immuno-oncology in TNBC, role of PARP inhibitor. So whether patients who have been exposed in a neoadjuvant setting, that particular subset was not there in the Olympia trial. So whether the patients whom we have given a pembrolizumab, as alluded by my previous speaker, whether we can give them olaparib or not. So again, in hormone receptor positive and HER2 negative, abemaciclib monarch E is there. So whether monarch E we can combine a abemaciclib plus a PARP inhibitor, or somebody who is a BRCA mutant. So whether in that setting we should give a abemaciclib or a PARP inhibitor, probably a PARP inhibitor and abemaciclib in a wild type population, that will be the answer. Again, role of capecitabine in PARP versus PARP inhibitor in triple negative, looking at the createx data. Again, will a patient who is a BRCA mutant definitely will consider a PARP inhibitor instead of a capacin wherever the indication is, because of the better hazard ratio. And again, PARP inhibitor plus radiotherapy as a radiosensitizer. PARP inhibitor in HRD subset, we saw the Ruby trial coming up now. And the whether like Oreo trial in ovarian cancer, somebody who has been exposed to a PARP inhibitor, whether we can rechallenge them or not. And whether we are again going to have a toxicity long-term use of PARP inhibitor in adjuvant setting. So the future is definitely exciting with PARP inhibitor in breast cancer. Next slide. So summary of my presentation: metastatic breast cancer, PARP inhibitor and triple negative breast cancer, answer is yes. In adjuvant, answer is yes. New adjuvant, the data is definitely encouraging, but yet to be standard of care. So with that, I conclude my talk. Thank you.
Thank you, Dr. Soumya, for giving such an in-depth session on PARP inhibitor and doing proper justice to the topic. Now we have a question for you from the chat box. The question is asked by Dr. Anjan Kumar Das. Can I use PARP after core biopsy, means before surgery?
Yeah. So the answer is that based on the biopsy report, core biopsy report, if your patient is satisfying the Olympia subset, that the patient is having a advanced disease and you are getting a BRCA mutant, then you can definitely go ahead as per the Olympia trial. So, but while using the PARP inhibitor, better to always stick to the guideline in the biopsy, the small biopsy specimen versus a larger MRM specimen, the difference won't be there. So if your patient is definitely a subset as per the small biopsy, core biopsy needle, then again you can go ahead with the PARP inhibitor if your patient is fulfilling the criteria of the Olympia.
Thank you, Dr. Soumya, for joining us. Now I hand over the proceeding to Dr. Chirag.
Yeah. So next in line, we have a debate. The topic of the debate is all triple negative breast cancer should be managed with neoadjuvant chemotherapy. For the debate, we have our expert, Dr. Rajiv Agrawal, sir. Needs no introduction. He's a Senior Director of Breast Services at Medanta Hospital, Gurgaon. And speaking in support of the topic would be Dr. Vamshi Krishna, who is Director and Head Medical Oncology at AIG Hospitals, Hyderabad. And speaking against the topic, again, she needs no introduction, Dr. Geeta Kadyaprat ma'am, who is Senior Director of Breast Services at Max Hospital, Parpaganj and Vaishali, who would be speaking against this topic. So over to Dr. Rajiv Agrawal, sir, our expert, to have the debate started, sir. Please.
No, Dr. Chirag, you can invite the first speaker. Hello.
Chirag, you are muted.
Yeah. I hand over the mic to Dr. Vamshi Krishna, sir, to speak in support of the topic. TNBCs to be managed with neoadjuvant chemotherapy. Dr. Vamshi, please.
Good evening, everyone. I hope am I audible and visible? And these are slides. Are my slides visible?
Yes, sir. Your slides are visible and you are very audible.
Full screen, visible, sir, visible.
Yeah, excellent. Thank you. So good evening, everyone. And thanks to Dr. Safalta and the organizers for calling me for this interesting debate. I always like going before surgeons. They end up showing a lot of pretty pictures that I do not have as a medical oncologist. So today my topic is NACT for all TNBC. And as I put it, it's for everyone. Now, before my opponent starts off, let's remember non-metastatic TNBC, like all non-metastatic cancers, does have a subset. Now, a patient coming with a LABC, where even my expert opponent cannot do a surgery, or where the patient desires a BCS, which is not possible, I don't think there's any confusion. We can just remove this part from the discussion. Definitely NACT is needed because you would like to bring the patient for a surgery. If the patient desires it, do a BCS. What about early breast cancers, which are defined as T1A or T1B, or maybe even T1C N0? These patients have not been included in any of the trials of TNBC, and I very humbly accept that these patients should not be given NACT because that's not been included in the trial. The real discussion for us has been the T2 and above and the node positive. So let the debate begin in this. Now, over the next 10 minutes, What I will prove is the benefit of neoadjuvant chemotherapy. The major benefit of chemotherapy is improving the pathological CR. Now, pathological CR correlates with better EFS and overall survival. More importantly, we can decide about therapy intensification, and then we can actually incorporate immunotherapy and newer modalities of therapy, including not just immunotherapy, which I think every doctor among us has been fielding questions for the last 2 days about immunotherapy, but also the HER2 low therapy. Now, this is a new subset which is going to, I think, be very, very common for us in the next few years. So all this can be incorporated as you include NACT, as you include the treatment of TNBC. Why do we need NACT specifically TNBC? That's a subset which we all know does not do as well as your HR positive. The rates of relapse are higher. And in India particularly, the outcomes are certainly not as good as the other subsets. The early trials which reported NACT, that included the NACB B18 and the B27, those patients who had a PAT-CR, it's around 13% in the first trial, more intensified therapy where you actually started giving what we would consider a standard treatment now. That's including paclitaxel. Docetaxel along with the anthracycline improved your PAT-CR by 26 to 13%. More importantly, those patients who achieved a PAT-CR had significantly superior DFS and OS. Multiple trials have been done. I will not go into individual trials, but straight away jump to this CT neo breast cancer pooled analysis. Now, this is the Cortazar paper from 2014. It's very interesting because this paper was actually kind of commissioned by the FDA because they wanted to see, is PAT-CR actually correlating with your EFS and OS? And can we use PAT-CR as one of the endpoints? What this study showed that those patients who achieved a PAT-CR, they had a marked reduction in the risk of recurrence and death. So you had a good event-free survival with a hazard ratio of 0.48, which is, pretty good. And an overall survival of 0.36, which is probably even better. Remember, these are patients who achieve a PAT-CR versus those who do not achieve a PAT-CR. Let's look at the subset analysis from this paper. Again, among all the patients, the triple negative cohort achieves the highest rate of PAT-CR of 33.6%. Now, of course, nowadays you have all your HER2 positives, you have your double anti-HER2, that segment is separate. But still, triple negative achieves a PAT-CR of close to 30 to 35%. And in those patients who achieve PAT-CR among the TNBC subgroup, the overall survival hazard ratio is 0.16. In fact, those patients who get PAT-CR in TNBC have a hazard ratio of overall survival of 0.16, which is big number which really cannot be disputed. Is this the only analysis that is there, or is 2014 too old? Let's look at this 2020 paper. Again, what did they look at? They looked at a comprehensive meta-analysis looking at pathological CR after neoadjuvant chemotherapy with an impact on breast cancer recurrence. Look at the HR for triple negative 0.18 for EFS. For OS, the association was again there for the TNBC. So you're having a pathological CR in TNBC, you get a much better outcome. What about the latest analysis? This came last year. Again, association of PAT-CR with long-term survival outcomes in TNBC. Look at this EFS of 0.24. This is the hazard ratio. When you look at the overall survival, 0.19. I don't know beyond this what we can do to decide that pathological CR does correlate with the EFS and OS. Yes, there are some papers which say that overall maybe the OS may not be significant, but we have to understand. In India, we do not have access to so many drugs. So anything that can give us a good EFS is as important as something that gives us an OS in the Western data. For example, my previous speaker showed you in TNBC metastatic, you have satisumab govitecan as a second line treatment, which is, well, pretty much not available in India. So you don't have many drugs available. So getting an NACT and identifying this group of patients who are going to do well is very important in India for us. Now, this is the FDA guidance again in July 2020, and at least for them, It's not the DCGI, it's not an Indian guideline for sure, but at least it gives us an idea that you can use pathological CR as a endpoint. This is specifically for trials. Now, can we improve this PAT-CR? Well, you have different options. You can use platinum, immunotherapy, and PARP inhibitor. The latest paper which actually looked at this is the brightness, which was again shown by my previous speaker. Now, this is an interesting study. They actually wanted to see if veliparib helps. What they ended up finding was that in the arm where they included paclitaxel and carboplatin, when you compared that to the veliparib arm, everywhere the best results were actually seen in the paclitaxel carboplatin arm. So in effect, what it told you was that, well, veliparib doesn't help, but certainly addition of carboplatin improves PAT-CR and improves the EFS as well. So you are having the neoadjuvant therapy, addition of platinum improving the EFS as well as the PAT-CR. Do we also see this in adjuvant? Studies are mixed. You don't have clear evidence in that stage. What about immunotherapy? Keynote 522, neoadjuvant pembro plus chemotherapy. This is in early stage TNBC. Again, when you look at the data, you included platinum and pembrolizumab. And then the patients, again, T1C with node positive or T2 to T4. So again, T1A, T1B, let's not go there. And there it showed that even in a stage 2, which is a 75% of population, and node negative, which is 49% of population, overall, the PAT-CR rate was better and the EFS is better by around 9%, which is significant for the TNBC. So again, in patients who do not achieve a PAT-CR, do we have some other option? We can always add capstabiline. Now the Createx, again, a study which we are all pretty familiar with. Those patients who did not achieve a PAT-CR or had a node positive at the end used capstabiline and found that the DFS was better by around 9%. The 5-year DFS here is 7%. So again, give NACT, you can stratify your patients and decide on those who require the capstabiline versus those who don't. That will give you overall survival as well as EFS benefit. Now, there was a study, SYUCC, where they used in all patients capstabiline, but I don't get the point of using an extra medicine when you know that it is useful for a subgroup of patients. Remember, Createx showed a benefit in TNBC. Now, the Olympia study again showed benefit in the group which was receiving NACT and in those patients who had a BRCA mutation. The hazard ratio again has been shown by my previous people. So for me, to summarize, TNBC locally advanced in BCS, obviously NACT. Very early, obviously no NACT. Early TNBC, improved PAT-CR, improving the EFS and OS. You are able to decide on capstabiline. You can investigate immunotherapy. So for me, NACT obviously yes. As they say, QED, as they say, Sachin is the greatest batsman of all time. Thank you very much.
Thank you, sir. Next, I would like to hand it over to Dr. Geeta ma'am to speak against this topic. Over to you, ma'am.
Thank you, Chirag. And I'm sure, Dr. Vamshi, you have very successfully tried to dig it in again. As far as surgeons are concerned, that, you're actually trying to push the surgeons out of the equation, but it is not that easy. While whether all TNBCs should be treated with NACT, I will speak against the motion. And I would acknowledge the dissenting voices of Professor Jayant Vaidya and Dr. Shalaka Joshi and many others who are part of this meeting. And I will, and they echo exactly what I think. So the rationale behind NACT, let's go back to then, that it is to render an otherwise inoperable tumor operable and to allow more conservative surgeries, hoping to lead to improved overall survival. And it's been about 30 years that the medical oncologists have been trying really, really hard to show overall survival benefit, but have failed. But so they catch the nose the other way around. So NACT does give us the opportunity to observe shrinkage of the tumor, both palpably and on imaging, and enabling a rapid assessment of clinical response. That's about what I think NACT does. Even if it is what you call a triple negative, though I know there are a lot of things that are happening. But little did we realize that while all this is happening, it is basically trying to push the surgeon out of a job. So what NACT does is essentially making an inoperable operable. I will come to the other PCR bits in a little while. This is the only rationale which I would say is valid and has led to desired outcome, but unfortunately this is a rare indication, because you did say that the premise of the NACT is actually an unmet promise, and we do know that there is no difference in breast cancer mortality or any death after NACT. So of course people talk about more conservative surgeries. Is that really the truth? So if you look at this Lancet paper, you see that the breast conservation rates in patients who were originally planned for mastectomy is only 33%. What about those who were eligible for breast conservation before neoadjuvant chemotherapy? So who land up with mastectomy due to possibly progressive or stable disease? But I'm sure the medical oncologist has got an answer, because now with immunotherapy, they claim to be getting more responses even with immunotherapy in advanced diseases. So what happens are, so sleepless nights for the surgeon after BCS post NACT. Spare a thought for the surgeons, because once you do neoadjuvant chemotherapy and there is a complete response, it is not an easy job for the surgeon. And don't forget the increased rates of IBTR. There is a 6.5% increase in the local recurrence rate with no difference in distant recurrence. Just a second. Oh, sorry. So role of surgery post NACT, not time yet to push the surgeon off the brink. So there is a 3.2% increase in local recurrence even with surgery in the neoadjuvant chemotherapy arm. And if you don't do surgery, and that is what we are slowly coming to, that no surgery after a complete pathological response, unacceptably high rate of local recurrence of close to 13%. So long-term outcomes of neoadjuvant versus the adjuvant chemotherapy in early breast cancer. This is a meta-analysis of individual patient data from about 10 randomized controlled trials. And if you look at the local recurrence rates, like I told you, it's about 5.5% at 15 years. And then I come to the buzzword, which is the PCR, and this is the new Scotch tape to silence surgeons. PCR, one should be very, very cognizant, should mean absence of viable tumor cells. Put a hand to your heart and tell me whether current methods of histology do guarantee that. RCTs have shown that avoiding excision of the original tumor bed, even with apparent PCR, results in higher local recurrence rates. So while you were quoting while my opponent was quoting the Cortazar paper, he possibly forgot to mention this last line, which showed in the interpretation that the pooled analysis could not validate pathological complete response as a surrogate endpoint for improved EFS and OS. So there you are. And in a recent study, which is there in the BMJ of 2021, they also suggest that pathological complete response should not be used as primary endpoint in regulatory neoadjuvant trials in early breast cancer. So of course we are on a wild goose chase. I really get confused when I talk to my medical oncology colleagues, because they put one combination over the other and tells everything works, and sometimes when something does not work, they reverse the combination and that works. So it's a plethora of drugs, and it is very hard to get around those tongue twisters. So carboplatin and taxane combination works well, just as Dr. Vamsi said, but do we use it as frequently as the anthracyclines? Because there is no data, not as much data as with anthracyclines, despite the worse toxicity profile with anthracyclines. If you look at immunotherapy, well, there was a lot of, we've been gushing about it, and we will continue to gush about it, I'm sure. In the iSpice study and the keynote, it showed very clearly that Pembro raised the rates of PCR from 22 to 60%. But look at durvalumab. We don't want to talk about it. You add it to chemotherapy, and there was no benefit. And atezo to chemotherapy, no improvement in PCR rates in the NeoTrip trial. So what did they do? They blamed it on carboplatin and taxanes, and then they changed the chemotherapy arm to Anthra, and then the PCR improved. So what's happening is you formulate a question. You know the answer. Then you formulate a question, and that gives you the answer that you want. So my question is, why harbor the disease for longer? We do know that complete PCR happens in only 35 to 40% with the best NACT. 60% of patients continue to live with the disease containing chemo-resistant cells through 5 to 6 months of NACT. The detriment of this delay is more pronounced in the smaller and better prognosis tumors in which NACT is being increasingly used, even if Dr. Vamsi says that's not the truth. So I will not, I think I'm coming to the end of my time, but this is a huge meta-analysis which shows that yes, in those patients where PCR is better, neoadjuvant chemotherapy is better, but in those where there is residual disease, adjuvant chemotherapy is probably better. So TNBC with negative lymph node, small tumor, early stage are more likely to achieve PCR. So what's surprising about it? And the poor survival benefit of neoadjuvant compared with ACT is determined by patients with residual disease. And of course, if it is early disease, we do know that NACT will yield higher PCR. So let's not throw the baby with the bath water. If NACT works so dramatically, I'm sure it would work as well in the adjuvant setting where the disease burden is low. And we don't have to worry about the resistant clones that may arise while the patient is on NACT. Most drugs which are tried in the neoadjuvant setting may be discarded if there is no improvement in PCR, but it has been shown time and again that they may actually work in the adjuvant setting. So don't hit the surgeon where it hurts most. The surgeon does like a good feel of the tumor, aids precision and excision. Lack of feel after neoadjuvant may contribute to higher local recurrence, and negative margin is probably fictitious as the tumor is no longer there but consists of multiple viable tumor cells, and of course the surgeon will get all the blame when there is a local recurrence. Surgery upfront, my dear friend, guarantees 100% response at the primary site. So are we barking up the wrong tree? And I'm glad lot of the talks earlier mentioned about the biomarkers. Let us start talking about with the TILs and the homologous recombinant deficiency in TNBCs, immune-related molecular signatures, and circulating tumor cells and ctDNA, and figure out which is that patient who's going to benefit from your neoadjuvant treatment rather than an adjuvant treatment. So let us return to the drawing board. Response at the primary tumor will be replicated at the metastatic site is a dream, but it is far from the truth. Should investigate alternative approaches to the window of opportunity trials, and please factor in the surgical outcomes. Neoadjuvant should be considered only in patients who have true LABC, inoperable upfront, or are borderline suitable for BCS to downstage. Let us strive towards true personalization, and if we do get a complete sustained response in most, only on systemic treatment with minimal side effects, my dear friend, the surgeon would be only too happy to walk into the sunset, because that is what we are here for, to ensure that our patients get the best of benefit from what we do. Thank you very much.
Thank you, ma'am. I think both the speakers have put their best foot forward on this topic. I would like Dr. Rajiv Kumar Agrawal, sir, to give his expert comments. Please, sir.
Thank you, Chirag. I think I must congratulate Dr. Vanshi and Dr. Geeta that they have spoken very well and they have put their point very well. And I think if you listen to one only, you will say he or she is right, and we will follow that. I think this debate will continue till the various subtypes of TNBC we define that which will be really benefited by neoadjuvant chemotherapy. Till now, there is no data that the overall survival, whether it is a neoadjuvant chemotherapy or adjuvant chemotherapy, is the same. It is the only subset of patients who achieve pathological CR, they are benefited. We do not know, to start with NACT, which patient is going to have a pathological CR. And in fact, it is the early disease, as Geeta said, And being a surgeon, I'll be inclined little more in favor of Gita, that it is the early disease, that is early T2 disease, which is likely to go into pathological CR rather than the late T2 disease. We are not talking of T3 or N1 diseases, but late T2 disease also may not get pathological CR. So unless we do a study that which patients, whether early T2 or late T2, go into pathological CR and they are benefited in overall survival, I think this debate will continue, and we have to find out subset of patients which are really benefited by NSCT, because we know that not all patients are getting benefited with NSCT. I think I will not take too much of time. If one of the speakers like Vamshi wants to rebuttal the Gita, he is most welcome.
To be honest, sir, I think what you have said has settled the issue. It is going to be a debate forever, and we need to identify those subsets. We need the biomarkers. There's no doubt debate about that. So, just as an aside, Dr. Ita, all my patients will go to the surgeon anyways. They will never run away from the surgeon. They're inescapable in today's MDT. So, yeah, but I think that's what it is. The search continues, and I do not personally feel we are going to go. I am not even confident about the dostarlimab data that those patients are not going to recur. We will need surgery, and without the surgery, the treatment is not complete. That's what I feel.
Thank you. Thank you, both the speakers.
Thank you. Thank you.
Thank you, sir. Thank you, sir. I would like Dr. Arun Goel, sir, to give the closing comments, sir.
Thanks, Dr. Chirag. First of all, I must really say that the talks by Dr. Sandeep Mathur, Dr. Panda, Dr. Venkat, they were all wonderful. Really increased my knowledge about all aspects of triple negative breast cancer. And then we had a wonderful debate. Just like to put a point one, that I would like to state again that when we talk of PCR, individual patient outcomes are okay. But at the trial level, PCRs do not correlate with the improvement in one arm. So we have had studies in which there is a PCR rate of 30% in one arm and 45 or 50% in another arm, without a significant gain in the overall survival outcomes in the trial. So as a trial level, definitely I would say that it is not and should not be used as a surrogate by FDA or other agencies to grant approvals based on PCR alone. And then later on, we may actually have to sort of either retract the approvals. And the other thing is about the PCR, how relevant is that? I still remember 10, 12 years ago, there was a publication that patients who had PCR, who even after mastectomy, if adjuvant radiation was avoided in that subgroup who had PCR after mastectomy, the local recurrence rates were higher than the group. So a pathological complete response as assessed today still does not guarantee even local control totally. So again, we need to really go further in this journey. So with that, I would like to say thanks once again to all the faculty, all the delegates. It was a wonderful response. Nearly 200 delegates have been there near the end of the event. So thank you once again, and we'll be back with the next event and we'll share the details once we have finalized. Thank you.
Sometimes in July.
Yeah.
Thank you.
Thank you.
Arun,